So sciatic nerve is the bundle of nerve made up of L4 to S3 nerve root, and it's the largest and longest nerve in the body. It supplies the motor function to the calf and the leg muscles, and also the sensory supply to the posterior and lateral part of the leg along with the foot. So sciatica is any symptom which is the pain along the course of this sciatic nerve. So this is how it comes out, make the bundle, and it comes out either through the piriformis or in front of it. So if you look at the course of the nerve, it comes out from front of the piriformis after coming out to the greater sciatic notch and kind of stays anterior to or deeper to the long head of the bicep femoris. So sciatica, as I said, is any symptom along the course of the sciatic nerve in the form of pain, tingling, and numbness. It's not a disease, but it's a symptom. So we have to kind of like find what actually is causing the sciatica, and because our treatment will be channelized as per the patient's actual pathology. There's no gender prominence. All of us, most of us are actually going to have some amount of back pain and sciatica in our lifetime. But if you look at the people at one point of time, then about 1 to 5% of the people are kind of running affected from sciatica pain at a one particular point of time. Now, physical activities, if you already are suffering from sciatica, will actually increase the pain. But if you are already physically active, then it's less likely that you are going to develop the symptoms of sciatica. Broadly, we can divide the sciatica symptoms in two main, from the standpoint of view, two main etiology. One is the spinal causes, and the second is the non-spinal causes. So spinal causes are, most of us are aware, is the prolapse intervertebral disc, spinal stenosis, listhesis, anything which is affecting the spinal vertebra or the spinal cord can cause the sciatica symptom. However, non-spinal causes are, I think, the main thing which we many of time miss. And out of these, most important ones are sacroiliitis, pelvic pathologies, piriformis syndrome, and muscle spasm. So disc prolapse is, we are all aware that it's the most common cause, and most of the time the patient, when you are differentially diagnosing clinically, then the patient's SLR will be restricted. They might have localizing sensory or motor symptom. One thing we need to be careful about that most of the time L4-5 disc will affect the L5 nerve root, but in these kind of situation, which you are seeing here on the screen on the right side, if the pathology is more foraminal or extra foraminal, then it can affect the exiting nerve root, that's the root higher up at that particular level. And this is the dermatomal and myotomal pattern, which you can kind of utilize while clinically diagnosing the level of the problem. Spinal canal stenosis will probably have pain not at the rest, but more pain at the after the walking and all, which is called claudication. However, many times they might have acute and chronic pathology in terms of disc prolapse coming out in a already stenotic canal, and then they can have acute and chronic symptoms. So that's how MRI picture will show us the stenosis. Spondylolisthesis is essentially the one vertebra slipping on over the other. Now the symptoms will be either of the spinal stenosis or the radiculopathy, which we have already discussed. Epidural abscess can be of multiple origins. Pain might be of in the night also, and there would be a lot of rest pain also. Along with that, patient might have constitutional symptoms, like in cases of TB and bacterial infection. More common in patients who are used to using IV drugs and patients who are immunocompromised. Now, coming to the non-spinal causes, I think the sacroiliac joint deserves special mention because this is the joint which we often overlook. Luckily, most of the time the MRI which we get covers the SI joint, if not completely, then at least the screening. So we are able to find out the pathologies. Clinically, I have not found SI joint stress test very useful because even in the proven cases of SI joint arthritis, I've seen that those tests were negative or they were kind of equivocal. But this kind of picture on the MRI and CT scan showing the eroding of the subarticular area of the sacroiliac joint and edema in the surrounding bone are more, I think, confirmatory. Piriformis syndrome is, I personally have not diagnosed any patient with piriformis syndrome, but I think it's diagnosed more by the physiotherapist. Symptoms are more or less same, and patient will have tingling, numbness coming down to the leg because of the sciatic nerve irritation or pressure by the piriformis syndrome can be more in the avid athletes and sometimes because of trauma also. Few tests are there like Freeburg test where you internally rotate the hip in the extended position, or you flex adduct and internally rotate the hip, and then you can kind of stretching the piriformis syndrome, so it will irritate the sciatic nerve more. And but I think it's more of a clinical diagnosis than any like imaging will show it. Pelvic pathologies also deserve special mention because these are almost always overlooked. So any pelvic pathology which can irritate the lumbosacral plexus will actually cause sciatic pain, and this is the list which I like found out from the internet. Pregnancy will also lead to sciatica, not only because of bulky uterus and other uterine issues, but the PIBD is also quite common in patients with during the pregnancy. And piriformis syndrome again can be there. Not only the pregnancy, but the labor while like delivering the child also, there is a lot of things which can affect the sciatic nerve. Lithotomy position itself, being in a same position for a long time, can cause gluteal compartment syndrome in a small and like short statured female with a big fetus. You can have obstetric neuropathy of labor, especially if there is a cephalopelvic disproportion. Sometimes there are case reports that epidural injection itself kind of irritated the particular nerve roots and led to the sciatica kind of symptom. And C-section itself can irritate the lumbosacral plexus deep in the pelvis and cause various symptoms. Muscle spasm is another etiology of sciatica sort of symptoms, where it's primarily the hamstring pull, which is seen more often in runners and sometimes in cases of acute trauma. Now here SLR might be positive because hamstring is at a spasm. Diagnosis is mostly clinically and by ruling out the other pathology. There are few other causes like abdominal, vaginal, and uterine surgeries which can irritate the lumbosacral plexus. Sometimes common perineal nerve palsy might be there, which you can think of a foot drop coming from the sciatic origin. So that also need to be ruled out. EMG will help there, and probably your dermatomal and myotomal pattern you will have to look at. Psychosomatic and malingering region also you need to be careful. I had a child, 16-year-old, totally bedbound. I saw in other hospital, I brought him to Safi and he was not able to move his legs at all. Psychiatrist saw the patient. Within 5 minutes, patient was walking. So, like you see these kind of cases also sometimes. Peripheral artery disease, where the pain will increase every time, and Dopplers and clinical examination of the pulses will be useful over here. Myalgia paresthetica, which can mimic the pathology of higher up in the lumbar spine. EMG, NCV, and your clinical examination of the symptom being more in the anterolateral thigh are helpful here. Hip and knee pathologies. So whenever we are examining the SLR and all, we are checking the patient hip and the knee joint also, so that at the same time you can rule out the hip and knee pathology, because hip pathology will cause pain in the anterior thigh, and the knee pathology can cause the pain running down the lateral part of the calf and can sometimes confuse us. So I have been asked to talk about a little bit about the treatment also. So before treatment, like we have to do certain investigations, and X-rays are almost always needed for multiple reasons, because you cannot see these kind of lytic fractures on the MRI. Many times they are missed even by the radiologist. Instability obviously we'll see on the X-ray only, because we can do it in flexion extension. These kind of deformities, to know the exact magnitude, you need X-rays. MRI is never the first line of investigation, but unless you have a patient with a quadricular syndrome or acute neurodeficit. CT scan is required whenever you are suspecting a bony pathology, or you have to confirm or rule out pars fracture sometimes, and check for the sacroiliac joint erosion. CT myelogram is useful when MRI cannot be done because of the presence of the pacemaker or aneurysmal coils, or if the implant is made up of steel was placed in the past. So CT myelo, I have done few, and I think it's a very useful technique to diagnose these kind of patients where MRI is not possible. Other investigation based on the patient's symptoms are these. And EMG NCV deserves special mention because it can differentiate between the different nerves which are affected and the level of the nerve which is affected, like common perineal nerve or myalgia paresthetica, where you want documentation also for the particular pathology. Treatment is primarily bed rest. Like any patient who comes to us is sent for the bed rest and lumbar orthosis. Pain medications, neurotropic medication, injections, and surgeries are another treatment options, which I think our other colleagues will speak about. Thank you.